to see you too, Soren, and Roger and Tan and everybody. Thank you for the pleasure of visiting. Great meeting, great discussion, and I know I stand between you guys and lunch, so I should be able to focus this a little bit, because when I was asked to talk about this non-inferiority trials, what do they really mean? The guidelines for the lecture were a little bit statistical, and so I did talk a little bit about the theory, but I thought I'd try and illustrate this by talking about something that's been topical in many of our minds, I think, as colorectal surgeons, which are the randomized trials done around laparoscopy for rectal cancer, the majority of which were non-inferiority based trials. So obviously the fundamentals of any good research is that we're going to do sound scientific clinical investigation. We're generally going to have a control group, although we've been talking about some conditions where we may not be able to do that, but obviously watch and wait and delaying surgery for rectal cancer. But randomization is the goal. And so studies are designed in a parallel manner. We have different types of controls that we use and different types of randomization that we can use. Most of the trials that we see are superiority trials. So a superiority trial assesses whether a new intervention is different from, whether that's better or worse than the control. And the null hypothesis, therefore, is that the outcome of interest is no more effective than the treatment or placebo, and you're trying to disprove the null hypothesis. So when you conduct a conventional superiority trial, the goal is to disprove that null hypothesis, showing that there's a significant difference in effect between the two treatment groups. For superiority trials, the delta or change between the two groups is generally fairly large. A significant value, significant p-value, in a superiority trial tells you that it's likely, because there can always be a false positive, that A is better or worse, depending on the way you direct your study, than group B. A non-significant value doesn't mean that the two treatments are equivalent. It just means that the null hypothesis wasn't reached. So a good example of a superiority trial is if you're evaluating a new biologic agent for IBD and comparing it to a traditional treatment, and you're looking at new methodology to see if it's better. Non-inferiority trials are designed very differently, and so it makes the results quite confusing to read sometimes, and often the concluding paragraphs challenging to understand, and the wording is challenging to understand. So the non-inferiority trials evaluate whether the new intervention is not worse than the control by a certain delta. For a non-inferiority trial, the null and alternative hypothesis are a little bit different though. So the null hypothesis is that for the outcome of interest, treatment X is worse than treatment Y by more than a described difference or delta. No matter how many times I read that sentence, I still find it hard to understand, frankly. The difference in non-inferiority trials, and this is one of the principles, the delta is usually quite small. So generally the change is 5% or less. And so consequently, non-inferiority trials tend to be quite large in the number of patients you need to recruit to prove your hypothesis. The interpretation of the p-values is the opposite of what you find in a superiority trial. So a significant p-value means non-inferiority or equivalence of the two groups. So an example of a trial that you might use to do something like this is comparing an oral to a standard anticoagulant. Obviously, you're not trying to prove that the oral anticoagulant is better than a standard anticoagulant. You're just trying to prove it's equivalent, but you've got to get an adequately large group size to show that, and that the difference is not significant. So if you then look at what those might look like, these are the hypothetical results of 12 trials, 3 of each showing either superiority, where the confidence intervals are all greater than the null hypothesis, inferiority, all less, or non-inferiority, where they don't cross this pre-study defined delta that we talked about. That might be up to 5% or whatever else. And obviously, there are studies that are done, or generally, if you do a meta-analysis, it's never as clean as any of the 3 upper graphs. More real life, when you have variability in what lines your confidence intervals cross. And that's when meta-analysis come in with all of the vagaries of interpretation of meta-analyses. So what about the errors that can happen with any trial, but particularly with these non-inferiority-based trials? Obviously, type 1, type 2 being a false positive. So the probability of accepting a null hypothesis if it's false. So consequently, you have to try and determine how do you decide if a trial result is valid. And then, consequent to that, if it's valid for the patient that you're going to treat, or for how you might apply that to your practice. So when you look at any of these studies, you've got to look at whether the appropriate endpoints were chosen, whether randomization and blinding were appropriate. And I'm not going to dive into this in the interest of time, but it's really important to understand and look at the study methodology. And we can talk about this a little as we talk about the few studies that I've picked. Let's skip this. And then when you apply that to your practice, is your patient therefore similar to those studied in the non-inferiority trial? Again, I'll allude to that in a minute. Is it similar to those in previous studies that demonstrated the efficacy of the control group? How is that going to fit in? And then you always have to remember that when a study is looking at a certain endpoint, how does that fit in the overall treatment of the patient? And how may that be outweighed by benefit in quality of life, or value, or some of the other things that we were talking about this morning. Some of the areas for particular caution, particularly in non-inferiority trials, are around blinding. And I'm going to mention the robot or ROLAR trial today, and although that wasn't non-inferiority based, blinding, it's a study where blinding is impossible, like many surgical trials, right? You're always going to know if you're using the robot to do a case. And therefore, it can become very subjective as in when you decide to convert. You know, maybe you'll try a little harder if you're somebody who believes in laparoscopy and you're doing it laparoscopically, or maybe you'll try a little harder if you're somebody who believes in robotics and you're doing it robotically, or what have you. And so unless trials are appropriately blinded, you always have to interpret the results of that trial in a manner that's aware of the potential biases. So talking about laparoscopy for rectal cancer then, where are we now? So there's obviously many papers in the literature. This is a recent one we published looking at some national data around the US. And when you try and correct as appropriately as you can for looking at any large national database with all of the attendant problems in doing so and in corrections, much like we heard about earlier on with mortality dropping recently, similarly in the US, cost is better, readmission rates are better, complications tend to be better, length of stay has dropped, obviously many other factors in there, and mortality has dropped even further. Other background before we set up the trials I'm going to talk about is the MRC Classic trial, which you all guys all know very well. And obviously within that trial there was a population of rectal cancer patients, and when the initial paper came out, there was obviously a lot of concern about the positive circumferential margin being 12% versus 6% for open. But then when the survival and local recurrence and mature oncologic data came out, those concerns did not appear to exist. And while the local recurrence rates were fairly high, around 10%, there was no difference between laparoscopy and open. And again, no significant difference in survival. And like many of the laparoscopic versus open trials, whether you look at colon cancer or something else, certainly not a few percent worse in the laparoscopic group, and if anything, a few percent better. And that's been a fairly consistent theme. And so there are the curves that that's based on. So that was the background coming into a meta-analysis that was done of the randomized controlled trials to that time around rectal cancer. And there were a few looking at the short-term outcomes. And really, when you look at the meta-analysis, the data were that a large multi-center randomized controlled trial was required. And several of those were done fairly contemporaneously in different parts of the world. And I actually thought before this I'd base this talk on a session I ran at ASCRS a couple of years ago, where we had Jaap Bonjer and Andy Stevenson and Jim Fleshman and J.O. talk about their trials. So what I did actually a week or two ago was email them and say, hey, send me your slides from the talks. And so I actually have their original slides, which I thought would be fun to look at, with a couple of edits. So this is just to try and show you what the groupings were and some of the differences were in these trials. So color 2 which some of you may have contributed to, primarily powered around 3-year local recurrence, 1,100 patients in a 2-to-1 fashion. They assumed a 10% local recurrence rate. The rectal cancers they looked at were those within 15 centimeters of the anal verge, excluding T4s. And this is something that I think gets forgotten when we talk about this trial, is that they excluded those in which there was a predicted circumferential resection margin of less than 2 millimeters. So while you can argue that this is probably the most clinically relevant trial in many ways around the surgery that was done and other things, they excluded some of the more challenging patients. So we do have to be a little bit careful. And the other nice thing about this study, obviously, it was straight laparoscopy against straight open, so it makes it a very direct comparison. The Korean trial was actually quite similar to that. You can see the slight differences there. 15% non-inferiority margin, tumors that were a little bit lower 2/3 of rectum, including T3s, including chemoradiation, and straight laparoscopic. And that's quite different from the ACOSOG and the a la carte trials. So the ACOSOG trial used a composite endpoint, and a successful resection was defined as a TME grade 2 or 3, plus a clear distal margin, plus a circumferential margin greater than 1 millimeter. And you can see a la carte was different to that again. A TME grade 3 only was called successful, with an adequate distal and circumferential margin. You can see the numbers, and these were the most similar two of the trials, apart from the slight difference in successful resection definition. You can see the similar numbers. You can see the similar but slightly different non-inferiority boundaries. So that number I was talking about earlier on, the 5%, so here it's 6 and 8. And then you can see the inclusion criteria, yet again slightly different. For ACOSOG, less than 12, stage 2 or 3, including neoadjuvant chemoradiotherapy, and patients were meant to be laparoscopic candidates before randomization, excluding T4s and those with BMIs over 35, which is probably a third or more of our patients, so a lot of exclusion criteria there. The a la cartes, fairly similar, but did include robotic. And then the big challenge around ACOSOG for many of us in the US was that open included hand assist, and hand assist may have included an open pelvic dissection. And so there was a lot of variability in hybrid kind of cases, but it was the goal was meant to be an open pelvic dissection versus a minimally invasive using whatever platform pelvic dissection. So you can see that even in trial construction and design, we're slightly comparing apples with maybe pears, maybe not quite oranges, but they're all slightly different here. So what about the outcomes? Well, again, as you're all well aware, color 2, there was equivalence in overall survival. And if you look at whether it's disease-free survival, no significant difference. Confidence interval crossing 0. An absolute difference of 4% in favor of laparoscopy, but obviously not statistically significant. Absolutely no difference in local regional recurrence. But what's really interesting from YAP's data and from the New England Journal paper is that if you look at so this graphic is broken up so that there's an overall positive circumferential margin in 10% of both groups, overall 5% local recurrence rate, and this is with mature oncological data, which is different from ACOSOG and a la carte, of 5% and p-values almost at 1. But it was different by location in the rectum. The upper rectum performed similarly, open or laparoscopic. The mid-rectum looks like it was a little bit more challenging laparoscopically, and the low rectum was significantly more challenging with open surgery. Won't dive into it now, but interesting perspective, and one can understand doing these, how those might both be true. This is JO's data around the Korean trial. So we've got a different table format. Essentially, this is just to look at the construction of the groups and the patient in the groups, and there was no significant difference. The vast majority of patients had a good quality TME, and you can see the circumferential margin positivity was low in both groups and not different in either group. And if you look at the survival and local recurrence rates, disease-free survival, 7% better in laparoscopy, but not a significant difference. Overall survival, fairly close to identical. And if you looked at local recurrence, you can see the differences here. 4.9% for open surgery, 2.6% for laparoscopy. And this was not significantly different, but certainly not worse for laparoscopy. So what about the ACOSOG and a la carte trials then? Because they're the ones that have probably caused the most discussion. I'll remind you that they're based on composite endpoints which are not oncologically mature. So they're these pathological surrogates for an outcome. And so if you look at these composite endpoints, and these are Jim's slides, which he kindly provided, you can see that open resection reached the composite endpoint in 86.9% of cases. And these are the components or constituents of that composite endpoint for TME, circumferential margin, and distal margin. And laparoscopy reached it in 81.7% of cases. You remember when we talked about how you design a non-inferiority trial, the trial reaches significance if P is significant, and it wasn't. So this failed to prove the null hypothesis, so they have not shown equivalence between these two approaches. ACOSOG, the reasons for an unsuccessful resection, and you can see here, incomplete TME, slightly more in the laparoscopics, positive CRM, slightly more, positive distal margin, no difference. And this I left in here because I just don't even know where this comes from, rectal perforation. It just should be so vanishingly rare. Anyway, interesting. Fascinating. Life is fascinating. And a la carte. So these are Andy Stevenson's slides, and this is really his summary slide because it was similar in a way. So the observed combined pathological success rate with the components there of laparoscopy was lower than with the open procedures, and so they also were unable to establish the equivalence of laparoscopic surgery compared to open surgery. And this is one of Andy's slides where he tried to put together a summary table, which I used because I thought it's interesting. Obviously, Classic is a little older, had a higher conversion rate. You can see the variability in conversion rate across the different continent sites and studies. Color, 17%, Korean, 1.5%, a la carte at 8%, and the US around 11%. You can see the leak rates, 10%, 7%, 1%, 7%, and 2%. You can see the mortalities, 5%, and the more recent trials, all much closer together, ranging from around 1% to, again, well, close to 1%. The CRMs, you can see, and the TME completion rate. So I think one of the things that's being discussed about TME completion, and that we're not quite clear, and I think it came up a little bit yesterday in the discussion, is where it's complete and where it's not complete. And so one of the things I think that many people feel who do laparoscopy is if you're using an instrument and you tear the mesorectum but it's away from a tumor, is that relevant? And that may explain that difference between the higher incomplete TME rate and equivalent local recurrence rates as we've seen in the Color 2 trial and was in the Classic trial. So where are we now with meta-analysis of the pathological outcomes? Because there is a recent meta-analysis of the pathological outcomes. And you can see that notwithstanding ACOSOG and a la carte's concerns, when you actually meta-analyze all of the data in the literature, there is not a significant difference, so it does cross the null hypothesis. So again, we're still in that zone of not being 100% sure and not really having enough adequate, mature oncologic data. I thought I'd conclude this in the last minute or two by talking about the ROLAR trial. So obviously that went on in parallel with many of these laparoscopic trials, and for people who believe in robotic surgery, this was obviously a very important study. Primary endpoint was around the intraoperative conversion rate, although it's not a non-inferiority trial. They assumed a baseline conversion of 25% in the laparoscopic group. They powered the study for a 50% reduction in conversion using robotics, had 400 patients in a one-to-one fashion. Alessio Pagassi was the lead in the US, David Jane was the lead in the UK. And so entry criteria were a rectal cancer suitable for resection by either robotic-assisted or laparoscopic surgery, who was fit with an appropriate ASA. So if you look at the primary endpoint, conversion to open surgery, laparoscopic group, 12% conversion rate, robotic group, 8% conversion rate, did not reach a statistically significant difference. They had a priori defined several subgroups to look at that might be high risk for conversion to see if it would reach significance for those patients. And so the biggest difference was seen for males, 16% versus 8%, an odds ratio of 0.46, and that did just reach statistical significance. For the lowest, I can't remember if it was lower half or lower third, of anterior resections did not reach statistical significance, and for obese patients did not reach statistical significance. There was no difference in circumferential margin positivity, so there was no improved quality of surgery that was being done with this. Obviously, the other challenges of the ROLAR trial were that the operative times tend to go up whenever you use a robot. And I'm going to talk about cost a little because I'm going to talk about value a little bit and where rectal cancer surgery might be in 20 years. But if you do look at the conversion rate difference in males, it's a 7% difference. Your number needed to treat would be about 11 patients to prevent one conversion. And so you have to extrapolate your cost per case using robotics in 11 extra patients. Can that be worth it when you try and put a value perspective together? And I certainly don't believe that's true. So in conclusion, non-inferiority trials are obviously important for us scientifically. I think we can be proud of us, for those of you who participated, and we did participate in the start of ACOSOG, but then pulled out. There was certainly a high level of effort put into all of these trials and the trial conduct and the quality of the trials. The short-term benefits of laparoscopy were confirmed, even including hybrid and hand assist cases in the open groups. Length of stay tended to be reduced by about a day, for what that is worth. And I think laparoscopy appears to be oncologically equivalent. It's certainly my interpretation of the current data because of the oncologically mature studies. But we do have to put a little asterisk on that and say that we're awaiting the data, the oncologically mature data from ALACART and ACOSOG. And there's currently no evidence that robotics adds value as an overall platform for minimally invasive surgery. Thank you, and I'd welcome you all to attend our meeting in Florida, and thank you for the opportunity of being here.